Hi, good evening, everyone. A warm welcome from Medgenome. Here we're gathered here to discuss about MetaSeq. It is a test which we have recently launched from Medgenome. This is all major pathogen classes are covered in this one powerful test. It has clinical relevant insight. It gives for 1,400 plus pathogen. It is unbiased, hypothesis free pathogen detection. It is a next generation sequencing test which is done from all clinical samples, mainly from blood samples in sepsis cases, is what we're going to talk about. And this particular test is done where we extract cell free DNA from the blood sample. Just getting into the urgent reality of global sepsis crisis. This is a 2021 data which talks about this is in children sepsis less than 5 years of age. There have been 20 million cases and 2.9 million deaths. Unfortunately, all of the 85% of all the sepsis cases occur in low and middle income countries. When it comes to India, 56.4% of the cases which happen in ICU are sepsis cases, and 45% of them are also multi-drug resistant. And we are still relying on traditional culture-based method, blood culture method for diagnosis of bloodstream infections and sepsis. It is time to upgrade our gold standard. It's a difficult thing, but yes, that's what we are striving towards. And we are introducing MetaSeq, which is a cfDNA based metagenomic test. Here, I'm briefly comparing it with culture, which is a gold standard and RT-PCR test, where a lot of tests are there in market commercially available. So what MetaSeq does is it detects bacteria, fungi, parasite, and DNA viruses. It is a hypothesis-free. 1,400 organisms can be detected. The sensitivity of this particular test, because we are doing from cfDNA, is really high. The number of biomarkers which could be floating around in the blood sample could be 10 million targets per ml for blood samples. However, when it comes to culture, it is less, and RT-PCR is even less. So why we are doing cfDNA based test is because we want to increase the sensitivity of this particular test, because blood culture, which is gold standard, the sensitivity of this test is very low, in 15 to 30% in all the practices. So MetaSeq, it's a cutting edge cfDNA metagenomic NGS based test directly from blood samples without the need of culture. This particular test is powered by Nocendo Discover's metagenomic platform with all its reference database combined with proprietary algorithm for precise clinical actionable pathogen detection using cell-free DNA. We have here Dr. Silky Grumes. She is a co-founder as well as the chief scientific officer from Nocendo, and she'll be talking about the technology. This particular test has a CIVD certification for bloodstream infection, sepsis, so endocarditis, meningitis cases, osteomyelitis, pneumonia, peritonitis, febrile neutropenia, and ascitic cases. All of these samples could be taken in where we have CIVD certification mainly for bloodstream infection. 1,400 pathogen bacteria, fungi, parasites, DNA viruses covered. This can be done directly in clinical samples. Here, RNA viruses not covered. So, with this bit of introduction, I'm going to introduce this team panel here. First, I would like to welcome Dr. Silky Grumes. She's from Nocendo, Germany. She's a co-founder and chief scientific officer. Um, Nocendo is an NGS diagnostic company which has advancing metagenomic sequences for clinical use across Europe. She has a PhD in infectious disease and molecular biology. Her expertise centers on cell-free DNA and infectious disease diagnostic. She has completed her studies from the University of Hohenheim, Stuttgart, Germany. I also have Dr. Nandini. She's from Apollo Hospital, Chennai. She's a consultant, clinical microbiologist, head of microbiology. She specializes in bloodstream infections and supports evidence-based infectious disease management. She is also an active contributor to scientific literature and national and international ID forums. Um, Dr. Honey is also here. Dr. Honey Savla, we've been closely associated with her. She had validating this particular test when we were doing internal validation from Indian samples. She's from Wokad, Mumbai. She's a renowned consultant in internal medicines with expertise in infectious disease, diabetes, and thyroid disorders. She has delivered over 500 national and international lectures and actively contributes to the research and clinical education in metabolic and infectious disease management. So, thank you, all of you. Happy and welcome. I'm happy to welcome all of you again, and we'll start off with Dr. Silky Grumes and followed by Dr. Nandini and Dr. Honey, and later we can have a detailed Q&A session. So we're just keeping it quite brief. Thank you, everyone, again.
Yeah, I'm just putting up the slides. Are they visible already?
Yes, they are.
Okay, perfect. Then thank you very much for the kind introduction and for the invitation to participate in your webinar today. And I would like to give you a short overview about how we use Discover in clinical metagenomics and what we do with the cell-free DNA and which kind of clinical evidence and studies we have provided so far. Just a very short introduction about our company, so that maybe you're not familiar with Germany and where things are located. So we have two sites in Duisburg, our headquarter, which is located in the west of Germany, and our laboratory, which is in the south of Germany, where I'm currently sitting. And we started our project in 2014 at a research organization which is called Fraunhofer in Germany, and then took the first clinical trials, which were very successful, and therefore continued on our journey to found the company to make this technology available in the clinic and in the routine. For our analysis platform, we gained CE-IVD approval in 2019, and recently in 2025, IVDR approval. And we have now expanded to approximately 35 employees and are ISO 13485 and 27001 accredited. Now, just a few words about cell-free DNA, because this is the analyte we are working with. So in the plasmatic fraction of the blood, when all the cellular components are spun down, you can find short fragmented DNA. This short fragmented DNA is mainly derived of necrotic and apoptotic processes, meaning this is mostly human DNA which is circulating in the bloodstream. In certain cases of infection, there are, however, also microbial DNA fragments found, and there are several hypotheses how these can enter the bloodstream. One of them being through the interaction with the immune system, where cells are then degraded and the genomic DNA is released into the bloodstream and is then further degraded by blood DNases. And on the other hand, it could also be due to the interaction with the antimicrobial therapies, which leads to a degradation of the bacteria and entering of the DNA. So this is why we're using the cell-free DNA to detect microbes from a blood sample. Why else? Because most of you are probably familiar with the limitations of the current blood standard, gold standard, which is the blood culture, that also there is a proven infection. In many cases, it will be negative. So in our routine and the studies we have performed, we usually have positivity rates of only 10 to 20%. And that is also in concordance with the literature. So there's a very urgent need for improved diagnostics in these severe infectious cases. And that's where using the cell-free DNA comes in. Because here on the right side of the graph, you also see a figure from a review from a few years ago, where you see that what is expected from bacteria in the bloodstream, even in a sepsis, is only 1 to 10 CFUs. Per milliliter blood, and therefore we need to cultivate it to increase their load to then have it detectable in blood culture bottles. But then on the other hand, there's also already several orders of magnitude more analyte available by using the DNA, and that's why we use the cell-free DNA in our test. This is an overview of the pipeline. The algorithm is called Discover and is the basis of the MetaSeq test by Medgenome. And it starts with a blood sample, which is then prepared for next generation sequencing in-house in the respective lab. And then after sequencing, the software takes the sequencing data, loads it into the cloud, and then there's an automatic removal of the human DNA by sequence adherence to the human genome. And then the remaining non-human DNA is compared against our proprietary microbial reference database. And then there's a patent and relevance assessment, which then leads to our report, which is available in the portal. And the whole process, just the software piece, takes approximately 2 minutes. And together with the wet lab piece, it's possible to have a detection within 24 hours. But of course, this also depends on the lot sizes and the overall process in the laboratory. So this might vary. And I brought you here a little example to illustrate for which patients it's especially useful and where the big advantages are. So this is a patient who suffered from leukemia and had several unspecific symptoms such as fever and a cough. And there were several blood culture testings which remained negative, and also some cultivation from BAL or tracheal secretion, and all of that was unsuccessful. When we got a test from this patient, we could find EBV and Rhizomucormiae, which is a fungus. And that could later on then be confirmed by PCR from BAL, and the EBV viremia was also confirmed by PCR, but only after this result was already available. And this, in my opinion, illustrates very nicely where this test has its advantages, because this is especially useful for patients who suffer from a broad variety of pathogens, and for example, also from pathogens which are very difficult to cultivate, such as this mucormycete. So to date, we have performed approximately 16 trials with more than 3,400 samples. Most of them are already published, but there are also a few manuscripts still in the pipeline. We mostly performed prospective and retrospective observational trials in ICU and emergency care, but also hematology and pediatrics. And most of them have in common that we have between 2 and 6-fold higher positivity rates in comparison to blood culture. We usually then also do an expert evaluation to compare our results with other standard testing, because the blood culture is so frequently negative. And there we got a very high positive and negative % agreement values usually. I would also like to give you a very short introduction to our DigiCept trial, because this is the first European interventional randomized control trial on clinical metagenomics, which we performed in Germany with approximately 23 large university hospitals. And there were 410 patients included with sepsis and septic shock. It was funded by the Federal Joint Committee, that's the GBA in Germany, with a volume of more than 3 million euros. And the patient recruitment was from March 2022 to August 2023. There was a health economic evaluation included, and also the costs and benefits in this case. What's also important is that the health insurances were also part of this trial. This is the setup. So we have on the left the control group of 205 patients, where the regular standard of care is performed. And then on the right side, we have the interventional group, where besides the standard of care, so blood culture, we also have the Discover test used. And this Discover result is then reported back to the clinicians, which then can use that to adapt the antimicrobial therapy. What we also did in addition is we also sequenced the data from the control group, but that was, however, not available for a therapy change, because it was the control group and not the interventional group, and we only used that for a retrospective evaluation. Then there was also patient survey data added, and the health insurance data, and the economic aspects. So just a very few results, because we're a bit short on time. What we confirmed here again was that we had a much higher positivity rate in comparison to blood culture. So we had two different time points, sepsis onset and 72 hours later. and the blood culture positivity was only 10.7%. In comparison, the NGS positivity was approximately 63%. We also had an evaluation of all the positive results regarding the plausibility by an independent expert evaluation, and that showed a plausibility of approximately 85%. Those cases which were not plausible were mostly double-stranded DNA virus cases. So, for example, where an EBV was found, which was not considered to be the clinical cause of the sepsis. And this is the summary of the trial in a nutshell. You again see on the left side the trial setup and also importantly the outcome parameters. So what we had here in the interventional group was a therapy change, an actual therapy change of 12.2%. And we had, based on all the data, also so control group and interventional group, the expert evaluation assess the overall estimate of therapy changes, and that was much higher. So the recommendation would have been 32%, but in reality, the actual change and the adherence was only 12.1%. Despite that, we still had very important clinical improvements in the intervention group, which shows here in this blue area. And was a reduced hospital length of stay, reduced ICU length of stay, a shorter time till shock resolution, shorter renal replacement therapy, shorter ventilation, and shorter anti-infective therapy. We also had an increase in long-term survival at 180 days, and increased quality of life at 90 days at cost equivalence of the intervention in the term of the whole patient costs. With that, I would like to switch gears a little bit and share with you some data points from the whole period where we operate in Germany. So since April 2020 and May 2025, we're only looking at data from Germany now. We have processed more than 10,000 patient samples, most of them which were adult patient samples, but also 6.3% pediatric patient samples. So the median patient age was 61 years. And as we also already heard in the introduction, we usually use this on blood because we have CE-IVDD and IVDR for our blood product, but IVDD also for BAL and synovial fluid, but research use only testing for other materials such as ascites or CSF. We served in Germany more than 150 institutions in this 5 years period and 72 locations, and most of them were maximum care hospitals in comparison to standard of care hospitals, which were approximately 1/3. Most of the patients came from intensive care, hemato-oncology, but also other units or general sent in, which was mostly the microbiology. And then also a few from cardiology, pediatrics, emergency care, etc., etc. Extracting here all the information that we found in blood, so we could detect in all these blood samples more than 770 unique species, most of them which were again bacteria, followed by double-stranded DNA viruses, some fungi, and also some parasites. And on the right side graph, you see the most common representatives of these categories. So for bacteria, we saw a lot of Enterococcus faecium, Escherichia coli, Staphylococcus epidermidis and aureus, but also Klebsiella pneumonia. For viruses, the most frequent one by far was EBV, which is also a frequent reactivation. Then some CMV, HSV1, HHV6, but also other reactivated viruses like the torquetinoviruses in immunosuppressed patients. Fungi, we see many different Candida species, the most frequent one being Candida albicans, and then also Aspergillus, Candida glabrata, Pneumocystis, and other Candida species. In Germany, we have a few parasites, so mostly from traveler patients. So there were a few cases of Leishmania infantum and Leishmania donovani, and also some Schistosoma manzoni and Plasmodium ovale and falciparum. With that, I'm already at the end of my presentation, so I hope I could show you that with metagenomic sequencing, we have a very useful addition to the current standard of care in diagnostics to add sensitivity, especially in these vulnerable patient groups who frequently suffer from very rare or difficult to diagnose pathogens. We have by now gained a lot of experience in Germany and have provided here a large German metagenomic data set, and we are very excited for all the data that will be coming from India. We usually show a much higher diagnostic yield in comparison to the standard of care and usually get a very plausible and expected pathogens, but in some cases also rare findings that might be diagnostically challenging. We see an increased acceptance rate in the German clinics and our partner laboratories, and our first European interventional RCT has a very positive impact on the patient outcomes and is a very important basis for the integration into the German healthcare system. With that, I'm at the end, and I'm looking forward to answering questions later on. Thank you very much.
Thank you, Dr. Silky. Thank you so much for the excellent talk. I think I'm really happy to learn that apart from sample, you've also got certification CIVD for bowel samples and synovial, which is very exciting, and I'm hoping soon we'll also have for CSF samples, because this is something which we really get in terms of metagenomics. That is the most after blood sample. I think CSF is the most abundant sample which we receive for
Yes.
metagenomic testing, because we offer this also a test as a clinical metagenomics at our end for CSF, where we do the DNA extraction. So exciting times.
Mhm.
Yeah, we've been associated with Nocendo and with you for last 2 years. We've been doing those extensive analytical validations where your colleagues were here in India and trained us, and we did all that analytical validation. And finally, it's here, and we have launched in exciting times. And I'm hoping that in India, all the clinicians will be really using this test, and it will be helpful for all the patients in all streams
Yeah.
of infections.
Yeah.
Thank you so much, and I wouldn't
Thanks.
welcome Dr. Nandini for her. We've been associated with her, I think, when we were. She keeps sending us samples, and I think she was the first ones to send a few samples to us for MetaSeq test, and I'm excited to hear her talk and how actually this particular test benefited the patients. So over to you, Dr. Nandini.
Thank you, Dr. Gunisha. So yes, I think we just stumbled upon this test when we were completely pushed to a wall with respect to this particular case. So we've used this test in two cases. I'm presenting both of them. And in both, it was completely eye-opening in both cases. So I'll just start with the first one. This was a 64-year-old male. One second, this is not moving. Yeah. So this was a 64-year-old male who was at the time of presentation residing at New Delhi, which is the capital of India. This patient had some known comorbids, including type 2 diabetes and hypertension, and he had been thrombolized earlier for a cerebrovascular accident 2 years before presentation. He also had a very severe bicuspid aortic valve stenosis. So, and he had multiple surgeries for this thing. Most recently, a year and a half before presentation, he had underwent a TAVI, which was an aortic valve replacement through the transfemoral route. So he presented to us last year in July, and the symptoms were like this. He had 3 months of fever, dry cough, and a weight loss of 10 kilograms, which was not explained by things like TB, etc., which we rule out immediately in such patients. Did not have many other associated symptoms like headache, vomiting, loose stools, dysuria, hematuria, etc. One stark symptom that he had was he started forgetting things, and it was not just very trivial. He started forgetting some people that he had known, in the recent past, etc. Did not have any suspicion of TB or any past TB or TB contacts. Did not have any addictions. He was initially treated in a hospital in New Delhi itself. The investigations done there had revealed some elevated creatinine and RA factor positivity, but otherwise within normal limits. Some basic radiology that was available to us in his charts were a CT chest, which showed some cardiomegaly and pulmonary edema, and chronic liver parenchymal disease. So basically, had a multi-system involvement by this time. At that time, he was just treated with broad spectrum antibiotics for 14 days and then discharged when it kind of became better. After which he moved to his home town in Bengaluru. And by this time, many of the doctors who had seen him felt that since he had an aortic valve replacement done, this was likely to be a prosthetic valve endocarditis. And since he had such a lot of exposure to healthcare facilities and hospitals by this time in multiple places in India, the expectation was it was some kind of a hospital acquired bug. But unfortunately, he had been seen by every possible specialty doctor in that he was a very well-to-do person. He had made his rounds through every infectious disease specialist in Bangalore by the time before we saw him. And his blood cultures on 8 different occasions with adequate volumes, with adequate antibiotic-free intervals had remained negative. So it was extremely frustrating. And his fever, unfortunately, persisted all this while. When he arrived at Chennai at our hospital, he was febrile still, 99.8 degrees in temperature, and did not have any very stark findings on general examination. However, his routine did reveal that there was a elevated blood urea, creatinine, and very high ESR and CRP. Again, the blood cultures which were sent here, I will show you in the next slides maybe, that again those also return negative. We generally pride ourselves with very good recoveries in blood cultures because we have good practices with volume, etc. But unfortunately, this was again negative. And like I said, since he had such a lot of healthcare exposure, the highest possible spectrum of drugs was given to him. That is ceftazidime, avibactam, aztreonam, and daptomycin to cover all possible bacteria by this time. His procalcitonin, however, was negative. He had some non-specific ANA positivity, which was negative on dsDNA and ANCA. Because of his CNS symptoms, he was also subjected to a MRI brain, which showed some neuroparenchymal atrophy with prominent sulcal spaces, chronic small vessel changes, and he had some microhemorrhages in both sides of the brain, cerebral and right cerebellar, because he had, of course, a lot of history of chronic hypertension and amyloid microangiopathy. Since the suspicion was there for endocarditis, and there were probably some negative reports earlier from the hospitals where probably a transthoracic echo was done. But when we did a transesophageal echo, we were able to see that there was a very, very small echogenic uneven mass, 0.47 into 0.4 centimeters at the tip of the anterior leaflet of the aortic valve. And this was suggestive of a query vegetation, which was query healed or healing, and it was difficult to assess. There was also some aortic root involvement in this TEE, which was also demonstrated on the PET CT. There was some increased uptake along that prosthetic valve, especially at the region of the aortic root. So there was likely some active pathology happening over there. He also had chronic pyelonephritis of both kidneys, which explained his increased creatinine as well, moderate hepatosplenomegaly, and some lucencies in the vertebral columns as well. Again, by this time, blood cultures and urine cultures continued to be negative. So again, we were pushed to a wall here. We wanted to also see if there was a fungal possibility. So a couple of biomarkers for fungal infections were done, which were unremarkable. So by this time, we had no diagnosis. We probably had, we didn't have an etiological diagnosis. We kind of thought that he probably had an endocarditis. And at this point of time, like Dr. Gunisha was referring to, we needed literally a hypothesis-free test, an agnostic test, because everything was open at this point of time. So we did order for such a test, and he was again discharged on these broad spectrum antibiotics at that point of time. So at this point, we considered a few tests. We thought we would do a broad range PCR for bacteria in the form of a 16S PCR or a broad range fungal PCR for ITS, and then do a targeted sequencing. This is something that we've had some experience with, not great experience with in blood, but yes, in other samples, we have been able to have some success when we sent for these things. And this patient, of course, was in no condition to undergo a cardiac surgery. So blood was the only possible sample in this particular patient. We also thought of a sepsis panel. There are some tests available of this category. And then we had done some reading for, shotgun testing, metagenomic sequencing. One of the tests that somehow we read a lot about was the Carius test, which is offered in the USA. So somehow at that point of time, I had not read about this Discover Nocendo test, but then this, of course, Carius was only offered in the US. And the problems with the 16S PCR was that generally in blood we've had very poor experience probably because of the PCR inhibitors that Dr. Grumes was also talking about. It's usually negative whenever we try to send in blood. The sepsis panel, we've burnt our fingers a lot of times with this particular test because you end up with quite a bit of non-specificity, as we did even in this case, and this was promptly ignored. This since Carios was not available, somehow we came to know of this test that was being tried at Medgenome at this point of time. I don't know if Dr. Gunisha would remember. I literally requested them to do this test for us because they were still validating it. They were not confident enough to actually, do the test and report it to us. But then, we were completely desperate by this point of time. So we did somehow coax them into running the test for us. And this is the result that it revealed. So this showed Coxiella burnetii, and number of species specific sequencing that it said was 58. Maybe one of you can explain to us what that means. And there was nothing in the negative control. So this was definitely something that was significantly seen in the sample versus the negative control. And you can see the disclaimer below there that this is RU only. We don't know if what we're looking for is correct and things like that. And since our experience was also for the first time, and we were completely thinking in the angle of a hospital-acquired infection, and Coxiella burnetii is something that is community-acquired, and we wouldn't think that this patient was a very well-to-do guy, would have had any animal exposure, etc. So we did send this patient sample to a center in India, to PGI Chandigarh, they had standardized a PCR for this particular organism, as well as they performed the serologies for this, both of which returned positive. And therefore, we had a confirmed infection by Coxiella burnetii. So finally, the diagnosis that was made was a Q fever endocarditis with multi-system involvement. And the treatment, this was probably the only cocktail he had not received till this time. So he was put on doxycycline and hydroxychloroquine, which is the recommended regimen for this particular infection. And as you can see that around the end of July and the beginning of August is when the diagnosis was made. And his CRP drastically came down, and by the end of it, his inflammation had completely gone. He had actually started recognizing the people that he was forgetting. I mean, the response that he showed was completely so amazing with this particular directed treatment that was given. And we continue to monitor his PCR positivity and antibody response even after this. And as you can see that the CT values constantly went up, which means that the microbial load kept coming down over a period of time. So a few words about Q fever. This is a zoonotic infection. So in fact, when we went back and spoke to him, he actually visited his farm in Karnataka once in a while, and he used to move closely with some of the animals in that farm, including cows and etc., which is basically where probably he got the infection from. Very rarely it's human to human. So there is an acute form and a chronic form. The chronic form is where you see endocarditis and things like chronic hepatitis, osteomyelitis, chronic pulmonary infection. And there is a post-Q fever fatigue syndrome, which is reported in 20% of the patients. The acute Q fever diagnosis is generally made with PCR and positive serology. This is an uncultivable organism. So there's no way in which we could have actually grown it in blood cultures at any point of time. Chronic Q fever, there is a serology positivity and PCR, which can be done both in the blood or the heart valve tissues. The treatment for acute Q fever is only a short duration one, maybe about 14 days. Whereas for chronic Q fever, it is a very long-term treatment that needs to be given, especially when there is an endocarditis that has been demonstrated. So if it is a native valve infection, at least for 18 months. But in this case, we had a prosthetic valve infection. So at least the minimum course is said to be for 2 years. This patient continues to be on doxy plus hydroxychloroquine, and also constant monitoring, which needs to be done with serologies, just to see if there is a fourfold decrease in antibodies. So that was something that this test alone was able to pick up, because we never really suspected it, and we confirmed the infection also with alternative testing. Soon after this, the second case we used this test was a 75-year-old gentleman who also had diabetes and coronary artery disease. He had been having some recurrent fevers fever, cough, and hoarseness. Previously treated as viral pneumonia, but did not really respond to that and developed some non-specific symptoms all across, multi-system involvement again. Persistent irregular fever, admitted for evaluation. He had some obstructive sleep apnea earlier, so a history of COVID pneumonia earlier, did have some ground glass opacities in the CT, multi-vessel disease on coronary angiography. So now we were dealing with a persistent fever with lung and bowel findings, and an infective etiology was also being entertained at this point. In this case, also, the blood cultures did not show anything. The malaria parasite was negative, respiratory panel was negative. There was no endocarditis as ruled out by the transesophageal echo. The vasculitis package, everything was negative. Tumor markers were normal. PET CT did show some mild colonic uptake, nothing in the focus. So basically, no focus of infection, had some multi-system involvement. So by this time, this was just the time after which we had this amazing diagnosis of Q fever with the test earlier. So we sort of sent it again for this patient. But this test in this point of time did not actually come back with anything. So that kind of pointed us to an alternate direction. And further evaluation actually showed that he had probably some IgG kappa paraprotein. And at this point of time, the bone marrow also showed morphologies which were suggestive of probably a myeloma. And because the test was also negative and all our other infective workup was negative, we were probably led in a better direction in the form of a myeloma. So this is just a case to highlight that I know we have not done an entire evaluation, but this actually did help us to avoid an infection of, a diagnosis of infection. And in that case, clinically, a negative predictive value was useful in this case. So those were my two cases. Thank you very much. And I look forward to hearing more about the test from our other colleagues.
Yeah, thank you, Dr. Nandini. Thank you so much. These are the excellent cases. I think some of the details, even I was not aware of, considering that there were 8 blood culture which had come negative at some other places, and a few more tests for all the infective etiologies were negative. And this particular case, reiterates that all these are culture. Some organisms which cannot grow in blood culture, and at such low levels. You had mentioned, I think what we saw here, just 58 sequencing reads. Probably Dr. Grumes can talk about, how important these 58 are. Also, probably later time we can discuss about it, because we have a cutoff values, and 58 is indeed a significant sequencing reads which we found. And how you correlated with PCR for Coxiella and also an antibody workup. I think it increases confidence in this particular test a lot. And I think the second case was also very important for us. I think for all the audience here also to understand the negative predictive value of MetaSeq is also very important. This is also important for de-escalation of all the empirical therapy which is given to patients. So it becomes very important. Thank you, Dr. Nandini, for accepting our invite. And these are two very important cases. I think are one of the first ones which we're really excited about. And again, thank you so much. And with this, I'll welcome Dr. Honey to share her experience with MetaSeq. She was also involved at the earlier stages when we were validating this particular test. So over to you, Dr. Honey.
Thank you so much. And am I audible well?
Yes.
Yeah. So after two great cases presented by Dr. Nandini, I'll be presenting the cases, but my cases are a little more acute. So let me share the screen. So I'll be talking how NGS helped me to save 2 patients and save the time to treat those patients. So it is about the technology. I have 2 cases. My case 1 is a 67-year-old male who had a non-resolving pneumonia, culture negative sepsis, who was deteriorating rapidly. And case 2 is about a female who was getting admitted repeatedly with recurrent UTIs and always landing up in ICU because of hypotension. The key takeaways will be highlighted at the end of the 2 case presentations. That is what I learned about blood culture negative sepsis. So this is, I think, already highlighted by the previous speakers that prior antibiotics reduces the culture sensitivity by 40 to 60% in the ICU patients, and there are certain fastidious organisms that require special media and extended incubation, which actually for in sepsis time is very important, and we lose that time when this things happen. And most important thing is polymicrobial infections. Conventional cultures end up missing the co-infections, and that is where antibiotics are not going at the right time and the right antibiotics are not going, and that's why we end up losing patients in ICU. So this is my first patient. He was a 67-year-old male who had suffered from stroke and was there in the previous hospital for a longer time. During this period, he developed fever, high grade, which was associated with chills. For like almost 10 days, they have been escalating their antibiotics, but there was no response. And they also saw that the patient is deteriorating and getting hypoxic. And that is when they decided to transfer to a tertiary hospital, the hospital where I work. And this patient had been transferred to us, and in the emergency itself he had hypoxia, tachypnea, and he had to be intubated right there, and he was shifted to ICU. Now this patient had received various antibiotics, and those antibiotics were escalated at the right time, but all the time, even in their place, even in their institute, the 2 sets of blood culture which they had sent had come out to be negative. They shifted to us. We did a CT chest because we had a doubt that we are probably dealing with a consolidation. So we saw that he had multiple patchy consolidation. It looked like it was a hospital acquired pneumonia, and there was a high suspicion that we are probably dealing with a multi-drug resistant organism, because the colleague in the previous hospital had used good antibiotics at the right dose. We decided to do bronchoscopy for this patient. The BAL was sent for routine culture. In India, we always send for tuberculosis. So gene expert TB MGIT was also sent. And blood also was simultaneously sent for NGS, because I was associated with Gunisha madam. So I decided that we'll send NGS because this patient has already undergone blood cultures and had got right antibiotics before. So it would be smart to, send everything together, because that is a challenge in all of this. And to my surprise, that in spite of doing a very specific test, the bronchoscopy culture had come sterile, and NGS result was pending. So now the only hope left for me was to wait for the NGS and hope that it itself gives me some diagnosis. So here we saw in the NGS result, when they came at the end of 5 days, we could see that the Klebsiella pneumonia was detected, and the patient was on antibiotics, but they did not respond to antibiotics. So probably we were dealing with a multi-drug resistant Klebsiella pneumonia, and that is why the failure of all prior empirical antibiotics was there. So we decided to start the right antibiotics, and when we started the right antibiotics, after 48 hours his inotropic support started reducing. We had to tracheostomize the patient because it was taking a little longer time to wean. So we started gradual weaning after the tracheostomy. He was off inotrope support, and then even the we could do extubation, and then eventually at the end of day 30 the even tracheostomy closure was performed. Following this, patient had good clinical improvement, and he was discharged from the hospital. Yes, he needed longer antibiotics, and he also needed a longer hospital stay for rehab and everything, but I think it was worthwhile because we could save the patient who had almost lost the hope in the previous organization. Blood cultures failed, and in our hospital we do PCR on the blood culture samples only if one of the samples flag positive. So we could not send PCR, sepsis, RT-PCR for this patient. So only way out was to send repeated blood cultures along with an NGS. Luckily, NGS could show us the organism, though the blood culture and the BAL itself did not show the organism. So it was a bloodstream hospital acquired infection. Uh, and we were lucky that we could save this patient. So if you look at the timeline of the event, he had a 10 days of fever in the nursing home, then was transferred to us. We had to immediately intubate, and then after intubating, we did a CT scan. Then we planned a BAL, but at the same time, we had sent the NGS on the first day of hospital only. And we saw that NGS had shown the growth of Klebsiella pneumonia. Targeted therapy started. Patient got extubated and was discharged home at day 40 of hospital. Though it required a longer hospital stay, but at the end, because of the right choice of antibiotics, he could go home after such a horrendous sepsis. This first case actually highlighted to me that importance, that what I always felt was that doing specific cultures, especially after doing bronchoscopy and after doing BAL, we can almost 100% locate the organism. But if someone has received previous antibiotics, even BAL can be sterile. And in those cases, the best thing right now which is available to us are this hypothesis free driven tests like NGS. Now, this is a very interesting case, a second case of a lady who I would never forget, because in spite of 3 to 4 admissions in the ICU with hypertension, they never lost their faith in me, which always just which encouraged me to go deep into this. Every time she used to get admitted with a UTI, it was urosepsis ended, always it was diagnosed as bilateral pyelonephritis, and whenever we did culture, urine culture, blood culture, they used to flag the gram positive organism, and based on that she was given a gram positive coverage, and the gram negative coverage was withdrawn because of antimicrobial stewardship. Now, this time when she got admitted, which was the third time, we had seen that enterococcus was there on the previous culture. So empirically, we started a gram positive coverage and a little lower cover of a gram negative. Like, we didn't go for a higher antibiotic like meropenem. We send the blood cultures as well as NGS and urine cultures. Now, since this, I think that what explains is that this has why the cultures were negative, because she has been having repeated hospitalization and repeated long courses of antibiotics also. By the time she had come for this third admission, her renal function had also compromised. The creat was around 2 to 3. She was on hemodynamic support and was spiking. So this time again, the blood and urine cultures were negative. They didn't even grow the gram positive organism. So now we were in the fix. Now, as I told you, we cannot send RT-PCR for this sepsis PCR panel again for this patient. So I had asked for an NGS sampling on the first day. So we were just waiting desperately for the result. In the same time, we were also escalating our antibiotic for the gram negative coverage as well as for the gram positive coverage. Hemodynamically instability persisted, and then finally the cell-free DNA NGS report arrived, and it detected Pseudomonas aeruginosa. Patient was already on meropenem. Patient was already receiving a gram-positive coverage. So this time we decided to start colistin. Obviously, renal adjusted dose was started, and in next 48 to 72 hours, her fever spike had come down. We had little challenges in adjusting the dose, but eventually the creatinine also settled. Patient did not require DJ stenting, as well as her fever settled, her count settled, and her inflammatory markers started coming down, and her fever improved. And after rapid improvement, once her inotropic support had been stopped, she was shifted out of ICU. So when I retrospectively thought about the case, I felt that we were relying too much on the blood culture, which ended up missing the gram-negative organisms, to my surprise. And that is why patient was inadequately treated, and that caused recurrent hospitalization and recurrent ICU stays. So because of NGS, polymicrobial infection could be seen, a co-infective or infecting organism could be identified, and right treatment was given. And after this complete treatment, she was never hospitalized till date for pyelonephritis. So it was very rewarding for this patient who had complete faith, and we could actually solve the problem with the help of NGS. So this was the sequel of what we had done. Day 1 of ICU admission, no improvement. NGS was ordered. All cultures had come negative. We detected eventually the Pseudomonas, and considering that it was resistant to the current antibiotic, we thought we were dealing with a multi-drug resistant one. Colistin was initiated, patient got better, stabilized, and was stepped down from the ICU. So what I have learned from both of these cases, one was a lung related to the respiratory system, other was related to the urinary tract. First patient was a male patient who had non-resolving pneumonia, probably a hospital-acquired one, where even the bile culture could not help, but NGS could identify the organism. Targeted antibiotics were started, we could save the patient. And the female patient who had recurrent UTIs, actually pyelonephritis recurrent, I should say, whose culture came to be negative, and probably there was a polymicrobial infection, which could be identified because of NGS and could be treated well. So this is how 78% culture negative cases can be resolved by NGS. There's a 5 days turnaround time, and it is 2 times faster in pathogen, because in cultures, if they come sterile, we have to wait and we have to send another set of cultures. But sometimes there are high chances even the second culture may be negative, but NGS can identify those organisms in spite of being on antibiotics. So my key takeaways and what I learned during this, like while handling sepsis, we have to remember culture negative does not mean that there is no infection, but because prior antibiotic exposure reduces the sensitivity by 40 to 60%. NGS detects the hidden pathogens. Basically, what happened in our second case was we were giving gram-positive coverage and maybe gram-negative coverage. We were not escalating following the antimicrobial stewardship, but yes, it required an escalation because there was a hidden pathogen. Precision therapy saves ICU stays, and that absolutely matches the cost which we are investing in doing the test. And early NGS in non-resolving challenging cases, be it acute or be it chronic, like doctor had already presented, NGS has a great role for improving survival, reducing organ dysfunction, and having better outcomes. Thank you so much for your patient listening.
Yeah, thank you, Dr. Honey, for these wonderful cases. I'm happy that MetaSeq, helped out in both the cases. What I feel, I think here we had as you mentioned, it was acute infection. One was Klebsiella and one was Pseudomonas. Probably they did not grow because they usually grow well in blood culture, and probably they did not grow here because of the therapy which is already the patient was undergoing, and probably the amount of reads what we had here again were not great. I remember they're in the same ranges of 20 or 50 sequencing reads which we have found. So they were not enough for blood culture or RT-PCR to catch on, and this was only possible with MetaSeq, where very low, because the sensitivity, because of cfDNA test, it is really high, and we could detect all of this. I think you also highlighted, you mentioned about the TAT. I think there are also a number of questions regarding the TAT in the audience questions. So you mentioned the TAT was 5 days. I also wanted to answer, there are 5 or 6 questions around that. So actually the working time, as Dr. Gumez also mentioned, with this test, we could give the report in 24 hours, 36 hours, but there is a transportation time, logistics time, and also, which I just wanted to mention because it goes on to add another day, because we get samples. Our core lab is in Bangalore, and we get samples throughout the country. And another reason why the TAT is slightly higher, I would say, is 3 to 4 days. We're seeing to that, we bring it down further, but at least now we are hovering around 4 days, because we sequence this on Illumina platform on a next generation sequencer. As Dr. Brumez had mentioned, that we have to generate a lot of data, because we generate kind of 8 or 9 GB of data, and that is because most of it, 99%, is host DNA and very little is microbial DNA. We have to generate large amount of data so that we can look and detect organisms, look for organisms in that whole lot of data after removing the host DNA, which is human here. So once you have to generate so much of data, you have to use a high throughput platform or a platform which could generate so much of data. Thankfully, Medgenome has high throughput sequencer, and we run them thrice or 4 times a week, so that we are able to maintain a 4 days of TAT. Now, rapid turnaround times are possible on an Oxford Nanopore platform. Probably there'll be questions around that. It's just that those quick platforms on Oxford Nanopore cannot generate so much of data in short period of time. And since we are using Illumina technology, that's why the TAT are slightly longer. But now, listening to all the cases from Dr. Nandini and Dr. Honey, I understand that patients, multiple blood cultures are done, and still they come out negative. So if it is this one particular test and gives you all the answers instead of waiting for multiple blood cultures, so there are some advantages, though the TAT is slightly higher on for this particular test. On this note, I think I'll just look through all the questions. I think a first question is around TAT. Then I think I've already answered that. Dr. Gumez, you would want to add something on this?
I can just add from a technical perspective that also with Illumina sequencers in theory, shorter times are possible, but then that depends on which instrument you have and how many samples. So I understand you have a setup where you have very large sequences, and of course you need a few samples to and collect them until the sequencer is full. Otherwise, it doesn't make sense. So I think that that's absolutely fair to say that depending on the sequencer that you have and the setting, the turnaround time can be shorter or longer. And in this case, it's 3 to 5 days. Yeah.
Right. And we have these NovaSeq X Plus. They're high throughput. We have other clinical loads. So it's just not we wait for the other sample. It's just that we run the high throughput ones, which also decreases the cost. I mean, if
Yeah.
I'm going to use smaller sequencing platform, the cost for generating 8 to 9 GB data is going to be really high. So
Yeah.
in India, it is also important to understand it is a cost sensitive market. And to generate so much data, I have to do on high throughput so that the cost of the test could also be lesser. Yeah, yeah.
Yeah, that's completely true.
Right. I think another question is, will this study be useful in patients in whom we have no answer, or in immunocompromised patients where we expect usually polymicrobial infection? So over to you, Grumes, Dr. Grumes.
Yeah, I can answer that. So we also did several studies in immunocompromised patients, and for them it's especially useful. So some people would even argue it's more useful for immunocompromised patients than for the regular sepsis patients because of the broad spectrum of pathogens that can be found, and that in frequent cases they will not be possible to grow. We also see it that there are instances where we have polymicrobial infections. So the usual case is from our general population that we get reports with 1 or 2 pathogens, but there are also instances in certain examples. For example, when you have a barrier issue, so when the gut is perforated or something like that, that you have very polymicrobial results with up to 10 pathogens, for example. So that would indeed be a very good application for the test.
Right. Thank you for that. And there's a question from Dr. Shadi Jacob. He's asking a question. Is there a scenario where culture shows heavy growth and DNA PCR is negative? Um, uh, Probably, I think I have not come across any scenario where the culture is positive, or and something test like MetaSeq, which is hypothesis free, will not pick it up. Dr. Grumes, did you have any cases? I haven't come across. Yeah.
Yeah, so we have that sporadically, but very, very, very rarely. And sometimes there are then like biological explanations for that. So, for example, we had a case which was Streptococcus pyogenes. However, it was a tissue infection where it was cultivated from a tissue swab. But we didn't find it it wasn't detectable in blood culture, and it also wasn't detected by NGS. But that's probably then more due to the fact that this streptococcus doesn't even enter the bloodstream. But it happens sometimes, but it's very rarely.
Right. And to answer the question, PCR could be definitely negative if it is not included in the panel, because as I mentioned, RT-PCR is hypothesis driven, where there could be a 20, 30 targets. So it's possible culture was positive for organ. I think more questions around the turnaround time, I think, which have already answered. There's a question about the DigiCep and Discover. I think in Germany you're able to meet the TATs, I think, using a smaller platform. Dr. Grumes, you would want to?
Yeah.
Yeah.
Yeah, so for the DigiCep trial specifically, and also for our German customers, we use smaller platforms, the NextSeq 1000 and 2000, where you only run up to 14 samples, and that's then possible within those 24 hours. So that was also a very important requirement for the DigiCep trial, to be able to see the intervention results in an adequate time frame. So we had to be very quick for that.
Right. I think there's another question for collaboration in India. I think Nacendo has already collaborated with Medgenome, so
Yeah.
we could
So
work together. There is, yes, I think that would
good.
answer the question. Yeah. How do you remove host DNA, and does that affect pathogen DNA? is one
Yeah.
question.
So that is done purely on a bioinformatic level, and therefore exclusively the human DNA is removed, and you can always set the filter settings to more stringent and less stringent, but we set it such that we make sure that there's nothing pathogenic being filtered out in the human filtering step.
Right, thank you for that. I think Dr. Jayakantan is asking, what about Mycobacterium tuberculosis in samples like ascites or pleural fluid? I think
Yeah, I think that's two questions. So we also have a mycobacterium detections, usually from blood, because blood is our main material. But we obviously also use other materials. We have used BAL, we have used ascites. I can't really comment on how many samples of mycobacterium there are, but in general, it's detectable, and also in those materials.
right. I think to that, I could add to that that Medgenome also has a test specifically for tuberculosis, where we can, which is called SPIT-seq. This particular test we have validated, I think in 2020, and we have a publication also in tuberculosis, where we can use both in pulmonary and extrapulmonary samples, detect Mycobacterium tuberculosis directly from clinical sample, and also provide drug-resistant testing. So if you're looking for something for tuberculosis specifically, then we have a targeted whole genome sequencing SPIT-seq test. I think that'll answer your question, yeah, regarding tuberculosis specifically. I think there was another question regarding pleural fluid and ascitic fluid for infectious agent. Apart from MetaSeq, we also offer metagenomics test, which we call clinical metagenomics, is a RUO test, which is where we extract DNA from pleural fluid and ascitic fluid, and we have seen this particular test has really caught on among all the doctors in India, where they are using this particular test for. This is a DNA-based test and not a cfDNA based, but it'll be great that soon we can use pleural fluid and ascitic fluid also on the Discover Sendo platform soon. But now this particular test we are offering on the shotgun metagenomic test, and we are getting excellent results, and we see a lot of traction. I think in the case of, what about pleural fluid? I've answered that. In the case where Klebsiella was seen, was the blood culture gram stain done to confirm negativity? So, Dr. Honey, for you.
Yeah, absolutely. So, because we were very careful with this case, the previous cultures were sterile, so it was done. It had shown gram-negative organism, but in the culture, the organism could not grow, and that is where we failed to identify the organism.
Right, and Dr. Grumes, you have an experience where something like a Klebsiella pneumonia not growing in culture. A reason being, if you want to mention few.
Reasons for Klebsiella not growing in culture?
Culture and positive by Nosendo's.
Yeah. I mean, that's basically mostly the usual case that the patients are already pre-treated, and therefore, so with antibiotics, and therefore the cultures are sterile.
Right. There's a question. Pseudomonas can be detected by multiplex PCR from urine. That was the question.
So I said, okay, basically, I already answered that. So basically, in our system, we have a rule that whenever the culture is positive, we immediately send it for PCR. We don't do PCR directly. At least that is how system works with us. But I have also seen places outside where they directly send PCR without the cultures growing it. So maybe if that would have been used, we would have got it or might not have got it. But that was a challenge, and that's why we directly went to NGS.
Okay, there's another question. Professor Arun Kumar is asking us if NGS can be done on watery stool. Since this is a non-sterile or not a sterile site sample, NGS can be done. We do gut microbiome. Medgenome does that to understand what taxonomy can be found out. But especially the test which we're talking about here, MetaSeq, is mainly for sterile site sample. It works well because considering there are a whole lot of microbiome which is already present in stool, we could use metagenomic shotgun metagenomics to understand what taxonomy is there in that. Okay, there's another question. There are other NGS platforms already. So how does this differentiate this technique from others? So Dr. Grumes, you would want to take that?
I guess this refers to Oxford Nanopore sequencing platforms, or I'm not sure if it refers to other technologies, so other pipelines. But I'm thinking I'm answering the first part. So with ONT sequencing, usually it's the problem that the accuracy is not as good as with Illumina sequencing, and therefore the differentiation on the species level is sometimes difficult, and also they are specialized for longer reads, and that's that's why we currently rely on Illumina sequencing for the time being. But I anticipate that this is also something that will develop within the next years, so that it's conceivable that this can also be extended to other platforms. For more accurate platforms, which are now launching, like the Aviti system, for example, we have already started first tests, so that's less of a problem because it's more comparable to Illumina sequencing.
Right. Yeah. Thank you for that. I think there's one question for you, Dr. Grumes. Dr. Grumes, you have used blood samples for cervical cancer patients for HPV. Dr. Rajesh Murthy wants to.
Oh, no, that is a very specific case. We unfortunately haven't had, so at least not to our knowledge. I don't know if something was sent and we didn't know about, but I'm not aware of these cases. Yeah, sorry.
So how do you differentiate between commensals and pathogens? And can we differentiate between cfDNA from a live pathogen and a dead pathogen?
Mhm.
So would you want to answer that, Dr. Grumes?
Yeah, so I mean, we generally do contamination reduction using. So there are two ways. We have uh, uh, the previous workflow was relying heavily on using batch controls for contamination reduction, and we have a newer workflow which is using a certain labeling in the sample itself to remove contamination. However, it can always be the case, and I think it's a tricky one where we don't have an easy answer on that, and that's something that we need to find out as a community in the future. What if this is discernible, for example, by signal size or location, etc. So I think currently it's difficult. We do it by contamination reduction and integration of the signal, but it could be that there's more to that, and we have to find out.
Right. I would just want to add to this that, removing contamination, commensals, and all the environmental contamination because nothing is sterile. And I think the whole beauty of this diagnostic platform and what we have from Nacendo is that they have a beautiful algorithm to remove all the contaminations and all the environmental contamination because take water and you put it on an NGS platform or any kind of a sequencing platform, and you will find some reads coming on. So it becomes very important to have the bioinformatics diagnostic platform which Nacendo has developed to remove all of this. They have a database of contaminants which is screened for so that the background could be removed and the organisms which are actual causative organisms could be reported on. So I just wanted to add on to that.
Thank you.
Yeah. We don't usually do tests to identify viruses, especially in blood. Do we have any articles suggesting viral sepsis where the patient is in septic shock? Probably this particular question, Dr. Nandini or Dr. Honey, if you could take that. What is your experiences with virus and sepsis cases?
Sorry, what is the question again? Viruses and sepsis.
Yes.
Viremia.
We don't usually do tests to identify viruses in blood. We have
Yes.
articles there. So it's not viral sepsis, but yeah, I mean, we do CMV viral DNAs, etc. in blood, right? So a lot of DNA viruses do cause viremias. It's just that they don't cause the same kind of SIRS that bacteria do. So the blood viral loads are done for various viruses, right? HIV, hepatitis B, hepatitis C is routinely done. CMV is done, EBV is done. BK virus is done as part of transplant monitoring. So it's not unknown that viruses cause viremias, especially the DNA viruses can be detectable. And we have PCRs for some RNA viruses also. Especially some of the arboviruses, dengue, etc., is done on blood. But it's just that they don't cause a sepsis. It's more like a viremia related to a systemic
Immunocompromised, yeah.
sepsis. Yes.
So how important it is to detect these viruses? I mean, in terms of how are you going to treat the patient? So detecting all these viruses helps you out in clinical practice.
Yes, they
Suppose
are
in
part of
MetaSeq,
various
like
algorithms, especially
yeah,
like I said, for especially in transplant and stuff
right.
where you have to monitor, either CMV disease that becomes uncovered post immunosuppression. That's where it becomes and things like reactivating viruses like these herpes viruses. Sometimes you need to know if you're dealing with a new infection or a reactivation, things like that. That's where it's useful, and of course to treat in those cases, CMV disease especially.
So immunocompromised patients many times have multi-system involvement, and those involvements are very confusing because you can get in bacteria, you can get in fungus as well as viruses. In those cases, we can start antivirals if we have this testing done, and it plays a very good role over there.
Yeah, thank you for that. Yeah. I think another question, we may not get intact DNA or RNA from microbes in plasma. In that case, how far the NGS-based test is reliable in terms of sensitivity and specificity? Dr. Grumes, you want to take this?
I'm not sure if I understand the question. So if we don't expect to get intact DNA because it is already fragmented.
So I think the beauty of the test is that, I mean, we detect the fragmented cell-free DNA.
Yeah,
We don't need the intact DNA, and we need actually fragmented because the cell-free DNA sizes are very small. They're
yeah,
like 120, 100 bases. To answer the question, we don't need intact DNA. Absolutely, a smaller fragment, 100, 120 bases are perfect for us to go ahead. I think for the human cfDNA are slightly bigger, like a 160 bases, and with microbial are even smaller. So smaller it is, this particular test works wonderfully. It can detect all broken, apoptized, necrotized DNA. That's how the cfDNA is, and it beautifully detects in this particular test. So
If I can just ask another question related to that. So, Dr. Grumes did mention that the human DNA is subtracted at the bioinformatics level. So we basically end up sequencing a lot of human DNA also.
yeah.
And I have read that, there is a lot of microbial DNA that has actually got into the human genome. As in, there are microbial fragments, which is probably one of the reasons why there is some non-specificity, right? So you're actually sequencing host DNA, but you end up with fragments of microbial DNA because they have sort of been assembled into some of the bioinformatic pipelines. I don't know if I'm articulating that very
Yeah,
correctly. Yeah.
yeah.
So
I think what
is
you're
that a
referring
possibility? Yeah. Yeah.
I think what you are referring to is the cleanliness of the databases, and that's obviously also something that we put a lot of work in because the public databases that are usually used and the genomes which are deposited there are not always that well curated, and there can be errors in there due to incorrect sequences from other pathogens, for example. But that's part of our pipeline curation, that there's a lot of work put in there to clean up those databases.
Thank
And do
you.
you upgrade those databases? Like now, since it's 5 years, 6 years basically, from 2020, you've got the test. So are
Oh,
you upgrading
yeah,
it
yeah.
regularly?
Yeah. That we have continuous updates, and we also need to document then obviously which changes were done and resubmit it to the authorities. But there are continuous updates. Yeah.
So you mean to say that 5 years down the line, like 5 years from now again, so whatever testing will do will become more specific, or there are chances that it may remain the same after the upgrades or updates which you are doing?
I mean, honestly, I would think it will stay mostly the same because there's not a huge list of genomes that will be added. There might be a few more which are rarer, but I would say that the most frequent ones and the most pathogenic ones are already in the database.
Right. I think we'll get on to the next question. Which genes are targeted in this technology, considering the cfDNA fragments are shorter in length? I think Dr. Gomez,
Mhm.
you will have, because
Yeah,
that is a
and
secret, though. Yeah.
yeah, and that's the beauty of it. We don't need to target specific genes. We just take whatever is there and see how it aligns to the genomes in the database. But it could be it could also be non-coding regions, etc. So it, however, needs to be specific to a certain taxonomic area.
Right. I think next question is why RNA viruses are not um, uh, detected in MetaSeq, which is more common infection in Indian population. I'm not too sure of that. Probably Dr. Nandini, if you would want to take that question, you know, are there any RNA viruses which cause infection, especially in bloodstream infection? Or Dr. Honey, if you'd want to answer that, they're really important. I understand. I mean, I will just want to give my 2 cents later once I hear from you. Yeah.
So, I mean, I think the name of the technology itself is cell-free DNA, right? So, I don't know if you can find
No,
free
I
RNA
no,
in the.
that's perfectly.
She's talking about
This does
incidents.
not.
Yeah.
This does not
Yeah.
detect. That is for
Mhm.
sure.
So,
I think we have.
but you do have blood PCRs for things like dengue, right? Which is,
Correct. No,
so
yeah.
that
My
way is
question
probably
was.
the question is probably related to that.
I think what I was trying to ask you was that we understand why RNA, because what I understand in clinical practices, do RNA viruses, is it important for you to detect, especially when you are having a sepsis or a bloodstream infections? Do you even
Definitely,
think
like if
of?
you're thinking of a dengue, for
Hmm,
example, a dengue septic shock or septic shock due to something like an any kind of arboviral infection, many of them which are RNA viruses, if you have a test that can also detect RNA viruses in one go, it's definitely useful in those cases.
okay, Dr. Honey, you
But
wanted to
yeah,
add?
so considering the sepsis load in our country, we have majorly gram-negative sepsis.
Correct.
Viremias and all may be seasonal, and maybe they are not as common if you compare the data with the gram-negative sepsis. And I think Western countries have more of gram-positive sepsis. That's what we have
So
been
again,
reading all
that
about.
depends on the kind of I mean, if you're looking at a community acquired, a patient coming from the
Hmm.
community with a sepsis-like syndrome,
Hmm.
I would definitely want an agnostic test to also include RNA viruses, especially if
Hmm.
you're thinking of dengue. But then I don't know, the technology itself justifies that because it's a DNA-based technology.
Correct.
That is what I
That is absolutely. Yeah, probably we in terms of, Dr. Grumes, anything from your side that why you did not include in your technology RNA viruses?
Yeah, so basically the whole process is currently optimized for cell-free DNA because cell-free DNA is more abundant than cell-free RNA. And we basically focused on implementing that clinically. And then a next step would be to the addition of also RNA material.
Right. Yeah. Thank you. And I think considering by the statistic of a bloodstream infection, I think RNA viruses come much later in considering first it's a gram-negative bacteria, gram-positive fungi, parasites, and then later on probably also it is probably not very important in sepsis kind of scenario, coming not from I'm a PhD, so I just wanted to give my 2 cents probably because of that,
I don't think it's an
considering.
importance issue. I mean, I would
Yeah,
disagree there. I think it's
okay,
more to do with, what you can do with the test.
sure. Okay, yeah, thank you, Dr. Nandini. I think should we consider adapting a smaller sequencing since sepsis cases require faster reporting? Yes, probably we could think of reducing our TAT. That is always we are striving for, Dr. Sundaresan. And if the infection is in lungs or urinary tract or elsewhere, which site of sample is likely more positive in a septic patient? Does a site of infection affect NGS positivity? I think probably Dr. Honey, if you would want to take this question. If the infection is in lungs or urinary tract or elsewhere,
Hmm.
which site of sample is likely more
So I think
positive?
testing on the specific sample is very important. Like whenever we are doing sepsis PCR panel, also we do for the specific tissue only. Like BAL NGS, if it would have been available, I would have been more happy. But as we are just extrapolating the results basically right now. Right now, whatever is validated is for blood. So that's why we could not use for our patients. But yes, I think having an NGS for the specific sample areas will definitely be more fruitful, according to me.
Right. You would want to add, Dr. Nandini, on this?
Yeah, absolutely. I think getting that is the one of the tenets of microbiology as such is to get the right sample as close to the site of infection as possible. But I think here we are talking about a test that has been validated on blood, so which is why we are talking more about blood. But that is not to discount that there cannot be a secondary bacteremia secondary to infections in other sites. So even when we do blood cultures, even if it's a pneumonia or a pyelonephritis, we do also a blood cultures just to see if there is, because blood samples are the purest ones. So yeah, site of sampling is very important if you've identified the source of infection. In our two cases, for example, it was a disseminated infection. So there was no singular focus. One of it, of course, was a heart valve. So blood is the only option that you have. So yeah, not to discount the fact that you need to sample as close to the infected organ as possible for in general microbiology.
I think there's, I think, one question which I could take. Um, uh, which platform is better, Illumina or PacBio, considering PacBio generates long reads? Here we are talking about a technology which uses cfDNA, short fragments. We don't need long reads at all. So I think Illumina works best. And we don't need long reads either by PacBio or ONT. But probably later, probably there would be a technology on something on ONT, as Dr. Grumes mentioned, but I don't think so. It's required especially for cfDNA. Um, uh, Another question is, what are the usual cases of false positives? So, Dr. Grumes, you would want to mention any false positive experience which you've had in your different clinical trials. I think DigiCep is one, but we've had other 13, 14 clinical trials and
Mhm.
many more publications. I think 13 publications, I think they've already have in this particular field. So you would want to mention about your experience with that?
Yeah, I would also say that is something that we rarely observe in our current setting. I just remember one from a pediatric population where there were some or also a larger trial from University Hospital Bonn, where there were a few samples which could not be in any way verified regarding to the pathogen. Um, so there can be instances, but then ultimately it's very hard to prove or disprove what it is, and therefore usually it's then reported like that that this might not be the cause, or at least it's unspecified whether that was actually the cause. So again, it's hard to get to the cause of it.
Yeah, actually, to add to this, even I had one patient when we were validating the result, where the culture was when we were validating, we were using culture sepsis and NGS to compare. So the culture was positive for Enterobacteriaceae, the sepsis PCR was negative, and NGS was positive for Epstein-Barr virus. So it was completely a perplexing situation where we didn't understand that whether using NGS was smart in this case or not.
Yeah, but that would have been a case then of false negative rather, yeah, if that was actually an enterobacteria, and the EBV, it was probably there. It was just a reactivation. That's usually something that if you would have run a PCR for EBV, you would probably also have detected it. But then it's rather the case of having missed the enterobacteria.
Hmm. Right. I'll just take.
If I can, sorry, add to that. Do you sometimes come across reagents that have strands of DNA contaminated? Some lots of reagents. I mean, is that something that happens? Or
Yeah.
the lab environment or something like that, or the
Yeah,
collection containers and. stuff
That
like
is
that.
definitely a common problem, and therefore it's very important to have efficient decontamination strategies by either using batch controls or using other measures such as we are doing currently. But that's the common thing, because the reagents, they are usually not made for these purposes. They are usually made for general, let's say, liquid biopsy testing, which is not focused to any pathogens, but just for the human DNA. And therefore, it doesn't matter if there's some contamination with bacterial DNA in it, but we would obviously find it, and therefore testing is important.
So does this test, which is offered by Medgenome, are all those steps actually standardized, or do you like occasionally change your reagents or stuff? I mean,
No, it is actually validated as per, we would not get the CEIVD certification unless we follow exactly what is done at Nosendo. And with each sample, we have to run a control, which acts both as a negative control as well as a positive control. We have to run that with each of the tests. Where the positive control, there are some spike-ins which have to come positive, where it is defined by number of sequencing reads, and different organisms which are there, which include viruses, bacteria, as well as fungi are there in the controls. They have to come, same sequencing reads have to, or similar have to come in. That was a very excellent question, Dr. Nandini, about about what is present in the kits and all that. There is ketome, which is a truth which is there, in which everybody thinks everything is sterile, but nothing is sterile. So that is why running a negative control is very, very important. So so whatever reads come into the negative controls are used for background negation, and also there is a database of negative control organisms which is built in the bioinformatic pipeline, which takes care of this.
you. And I remember using a Streck tube on both of the patients that we did this test on. Is that the only sample collection tube that you accept, or how about for the other non-blood samples? Because then the reagent bottle itself can be a source of, I mean, the sample collection device itself can be a source of contamination, isn't it?
Correct. So I think even other sample types, what I know of from Nascendo, that it can be collected in Streck tubes, especially when it comes to CSF, because here we are looking at CF-DNA extraction, and Streck tubes work best. Even if you're looking at other sterile site sample and other containers, I think those vacutainers, which are plain vacutainers without EDTA, those work best in terms of other metagenomic samples. But when we're talking about CFDNA, I think Streck tube, even if there are other sample types, Streck tube would be used. Dr. Grumes, you want to add on that?
Yeah, I can comment. We prefer to use Streck tubes because they stabilize the cell-free DNA by also stabilizing the cells which are in the samples and preventing them from releasing genomic DNA and increasing the human background. That's why we like to use those, because if you use normal blood tubes and you leave the blood standing for too long, you will have hemolysis, which increases the human background, and that's not ideal.
I think there are some questions regarding the cost, and I think that sales team could take that question at a later point. And there's also a question regarding, how human genome sequences is removed. I think we've answered that question. It is built in the bioinformatic pipeline, where the human host DNA could be removed bioinformatically. That is completely built in the bioinformatic pipeline. There's important question as to how to transport these samples. Yes, the sample is collected in Streck tube. We need a 10 ml of sample, and for pediatric or neonates, a little volume like as low as 3 ml will also do. The samples could be transported at room temperature, ambient temperature. But at Medgenome, we will always prefer for all infectious disease 2 to 8 degrees that the samples could be sent in to Bangalore, and the sales teams could be contacted. Yeah. So are there many more questions? Are there? I think I've reached the end, Dheeraj.
Yeah.
Okay.
So thank you, Thank you, Dr. Gunisha, for this wonderfully moderating today's session. And special thanks to our all three esteemed speakers, Dr. Silky for clearly explaining the technology which is discovered, and Dr. Nandini and Dr. Hani for sharing their positive clinical perspective on MetaSeq. Thank you all for an excellent session and patiently addressing every questions from the participant with our utmost dedication. I am confident that all the participants have greatly benefited from the discussion and that MetaSeq will find meaningful application in their clinical practice. So with this, we conclude today's session. Thank you everyone for joining us for this wonderful webinar. Thank you all.
I think that was
Thanks.
Dheeraj. We could not see you, Dheeraj, but yeah, thank you for organizing this. And I think he's been in touch with all the three speakers, and we'll continue to keep in touch. And thank you, audience, for a lot of questions and relevant questions. And a good night, everyone. Thank you so much, everyone.
Thank you very much.
Thank you.
Thank you.
Bye bye.
Thank you. Nice meeting everyone.
Yeah.
Bye-bye.
Bye-bye.